Hello all. Today I'm going to be talking about the future of medicine, healthcare professions, and pharmacogenomics. My name is Ann Savariar. I'm an instructor for the Pharmacogenomics program here at Manchester University. I teach Introduction to Pharmacogenomics as well as Analytical Technology 1 and 3 laboratories. So let's look at what pharmacogenomics is. Pharmacogenomics is really a portmanteau of two words, pharmaco meaning drug, and genomics, genetics, or DNA. So what is pharmacogenomics? It's the study of how genes affect a person's response to drugs. Moreover, the influence of an individual's genetics, meaning their DNA, on the response to certain medications, which is related to how well the drug is working, and it's related to adverse drug reactions. Let's look at some key terms here. So what are polymorphisms, mutations, and what are their differences? Polymorphisms are variations in DNA that are common in a population that occur at greater than 1% of the population. And mutations are DNA variants that occur less commonly and occur in less than 1% of the population. Now, polymorphisms and mutations may or may not lead to functional changes that we can detect. So, the following are polymorphisms. We have a SNP, which is a change in a single base pair. This is probably the most common polymorphism. We have insertions or deletions, also known as indels. We have VNTRs, which are repeats in the DNA sequence, and we have CNVs, which are multiple copies of a gene. An allele is one of two or more variations of a genetic sequence at a particular location on the genome. So if we have two chromosomes, one from each parent, let's say, for example, we have allele 1, which is big A, and allele 2, which is little a. You can technically have 4 different variations, which you could have homozygous big A. You can have heterozygous big A, little a, which actually would mean the same result. Or you can have homozygous little a. And phenotypes are an individual's observable traits. So it would be what you see. For example, eye color, hair color. In this case, let's look at eye color here. So the picture on the left shows blue eyes, and the genotype is little b, and it's recessive for blue eyes, which is the phenotype. And for brown eyes, we have the genotype big B, little b, or big B, and this is dominant. So the phenotype is brown eyes. So let's look at the results of different mutations here. So if we have the human genome, and we have a mutation, you can have single gene copies, and straight down, you can have a normal enzyme, meaning you have the level of enzyme that you need in the body that is considered normal, and this would confer to a normal metabolism of the parent drug. You can also have unstable enzymes or altered substrate specificity, which means you could have varying levels of enzymes, which can lead to decreased metabolism of the parent drug, or decreased metabolism of the parent drug, or maybe a little bit faster metabolism. You can also have a gene deletion, which means you have no mRNA transcripts, leading to no enzyme and no metabolism of the medication. You can have gene duplications or multiplications, which leads to higher enzyme levels and increased metabolism of the parent drug, which would lead to, so overall, we're looking at phenotypic status here. So if you have no metabolism of the drug, this would lead to a poor metabolizing status. If you have a decreased metabolism of the parent drug, this would lead to an intermediate metabolizer. If you have a normal metabolism, you are a normal metabolizing status. If you have, for example, a little bit quicker metabolism, you could have a rapid metabolizing status. And if you have a very increased metabolism, this would be an ultra-rapid metabolizer. So let's look at the consequences of the changes to drug metabolism. So earlier we talked about more rapid metabolism. So if we have a rapid metabolism of the drug in the body, the drug is actually considered ineffective because you would have lower levels of the drug and it would only work for a short amount of time. However, on the flip side, if you have a slow metabolism of the parent drug, this could lead to side effects, toxicity, and drug buildup, leading to adverse drug reactions. So let's look at the percentage of patient populations for which certain drug classes are ineffective, and we're looking at an average of populations here. So for antidepressants, they were found to be 38% ineffective. Asthma drugs are 40% ineffective. Diabetes medications are 43%. Arthritis medications are 50%. And Alzheimer's and cancer drugs are really high. Alzheimer's is 70% ineffective and cancer medications are 75%. So we have a range here from around 40 to 75%. Now, why are adverse drug events so important? Around 800,000 people are injured or die each year in hospitals from adverse drug events. And over 2 million people in the US experience adverse drug events every year, and adverse drug events are one of the leading causes of death in the US. And relating an individual's DNA to drug response can help prevent or avoid adverse drug events, leading to better efficacy. Let's look at a PGX example here. We have Ronnie on the left, who is the mother, and we have Tarek, her son, on the right. So 12-day-old Tarek actually died unexpectedly in Toronto, and the cause was due to a morphine overdose, but clearly he was not receiving morphine. What happened was Ronnie was receiving codeine for pain after giving birth, and genetic testing showed that Ronnie was an ultra-rapid metabolizer of codeine. So because she was converting codeine so quickly, and codeine actually turns to morphine in the body or converts to morphine in the body, this morphine was being excreted in breast milk during feedings, and Tarek was being dosed with morphine during breastfeedings. So he was a normal metabolizer and an infant just recently born, so he was not able to process the morphine that he was being given, so he passed away. And this is one of the very clear examples of why PGX is so important. Now let's look at how pharmacogenomics is used in different healthcare professions. So for physicians and physician assistants, they can develop complete personalized treatments to provide their patients quality and value care. They support clinical decisions for safe and effective medication treatments, and this really eliminates the trial and error method that we see. And pharmacists are really important. They are really leading the way in pharmacogenomics because they work together with genetic counselors to educate and facilitate decisions made with the physician. They provide well-informed individual treatment inputs. They advise on drug selection, dose adjustments, alternative therapy, and drug monitoring based on the genetic testing results. They can educate providers and patients on how genetics affects the drug response and also explain what genetic testing results mean to the patients. Now, nurses, often at the bedside, they educate and inform and discuss overall treatment to patients and family. They can really showcase the benefits and limitations of the therapies. They can monitor more accurately and comprehensively on patients' response to treatment and avoid adverse drug reactions as they are often at the bedside. And really, this helps improve the quality of care to patients. Genetic counselors work together with pharmacists to educate and facilitate the decision-making for the physician or physician assistants. They can inform and assist the physicians about using and interpreting genetic testing and pharmacogenomics information. They can educate and facilitate during counseling to assist the patients in making informed decisions about the treatments, and they can explain the genetic components of testing and results to patients as well. So thank you for listening to my presentation on pharmacogenomics and the healthcare professions. If you have any questions, please reach out to me. My email is aksavariar@manchester.edu, or you can also reach out to Julie as well. I hope to see you guys in the future. Please stay well, and we hope to see you soon. Thank you so much.